before its time and almost total failure. So I get a particular sense of reward that, not that they're actually working with one another, but they're meeting one another, and they're exchanging business cards. So this is actually a major breakthrough. The other thing that we've been spending a lot of time at, and we have an absolutely enthralling paper, another paper coming out that the SCAN Foundation is going to publish itself, because it's really not quite academic and it's not quite policy, and is if you're really committed to the notion that individuals, to the extent they're cognitively capable, and their caregivers, to the extent they need help with dealing with cognitively complex issues or with communicating, should have some real control over the kinds of services they receive and the kinds of medical care they receive, then figuring out the extent to which they feel they have that control, and further, figuring out the extent to which they feel that they are being well served by the people who are providing them with care, is in fact a principal outcome measure. It's not sort of an intermediate measure or a facilitative measure. None of these folks are going to be cured. None of these folks are going to have clinical outcomes that anybody is happy with at the end of the day. They're all going to die somewhat more quickly, or very much more quickly, than other people of their age and socioeconomic status. The real question is, are they in a relationship that permits them to manage that process with as much a sense of control, of dignity, of autonomy, as much of an absence as is possible of anxiety and fear as possible. And frankly, our paper came about because when we learned that RAND had a contract from CMS to modify HEDIS for hospice patients. And after I stopped screaming, I decided we needed to do something else about it, because in fact most of our quality measurement tools these days, including most of our tools trying to get at questions of patient satisfaction, don't come anywhere close to addressing the kind of issues that are most important to people with advanced illness, and most important to them in terms of their relationship with the care delivery system. And so we don't have a solution to that at all, but we have some things to say and some suggestions about how we could learn a lot more about how to do that better than we're going to, I fear, in the world of value-based purchasing and all that kind of stuff. So, so why isn't everybody doing it? Well, the reason, if you talk to people providing this kind of care in a way that's exemplary, the first thing they always say is that, Medicare won't pay for it, or Medicare won't cover it. I've never heard people say that before about anything I ever encountered. And in fact, I think, not having been trained as a clinician myself, I think that it's probably part of the new competency-based residency exams that when physicians are trained, when anything sort of, they fail to do anything they were supposed to, and the question is, why did you fail to do that? Well, Medicare won't pay for it. I mean, that's certainly part. We don't license healthcare administrators, except for nursing home administrators, which is a very sore subject among nursing home administrators. But I think it's part of the finals for every MPH and MBA program in health administration as well. Why is there a terrible shortage on the West Coast of the wheatina that my father-in-law loves? Well, because Medicare won't pay for it, obviously. And so that's the reflex in all of these things. But to some extent, they have a point in the sense that the kind of services that are provided in these programs require much more intensive primary care management and care management than the fee-for-service system generally pays for, although we're experimenting with new ways of doing that. In fact, we didn't want to give away the whole thing and give other people all the credit for the work we've done. They look a lot what primary care medical homes are supposed to do in a variety of ways, although very few places that the NCQA is certified as primary care medical homes really do all of them. But and the lesson there is that actually two of our sites were particularly instructive in the sense that they served large numbers both of fee-for-service Medicare beneficiaries and Medicare beneficiaries enrolled in Medicare Advantage plans. In a couple of instances, plans that were actually controlled by the providers, in a couple of instances, plans where there was a willingness to subcapitate the providers. And they made lots of money on their capitated patients who were enrolled in these programs and lost money, not a whole lot of money, but they lost some money on their fee-for-service patients. And so that's been a barrier. A bigger barrier is that most healthcare professionals don't know how to do this kind of thing. There's an enormous gap in education and experience. There's now a growing amount of literature. At least once a month there's an article about well, you don't teach residents to talk to people and so forth in the New England Journal, and every issue of academic medicine. But it's a real gap. And then you do need the whole set of organizational infrastructure, just like you need it to run an ACO or to operate a primary care medical home, of which the IT infrastructure is the most expensive, the most visible, and the one with the greatest gap between expectations or specifications and actual performance. You also need an organization that's really committed to doing this, that is really committed to investing in these kinds of services and in a way investing its patients. And particularly for big medical centers or big physician groups, they have to balance their commitment to these kinds of programs and the investment and the cost and the hassle of running these programs over time with cultures that have really been very much oriented towards cure, towards making ever faster and more precise, technologically intensive innovations, to not necessarily developing relationships with patients because that's too time consuming, to increasing throughput it's like the whole world was run by surgeons. There needs to be a very basic kind of, in order to maintain the organizational commitment to the extra training, to the more selective recruiting, to changes in the reward system to support people who spend an extra 2 or 3 hours, to the nurses who give patients their personal cell phone numbers so that they have 24/7 access, and so forth. And there's still not a whole lot of healthcare organizations that care enough or think it's important enough in order to make those kinds of commitments. It's very hard work to do this, and in order to maintain it and operate it over a period of time, you need not only to recruit people who are committed to it and interested in doing it and know how to do it, but you got to support them over time, and that's a continuing investment. Having said that, if you do all this, you reduce inpatient hospital use, although all the numbers are preliminary and they're limited and they're from a small number, and this is not, scientific, but it's really a little bit worrisome because what they mostly do is reduce terminal hospitalizations. That is to say, people in these programs die at home. And they're not hospitalized in the last 6 months of life for something that if they get hospitalized for, it maybe won't kill them, but if they get treated at home, maybe it will kill them. Because they've said, I don't want to go to the hospital. If I die at home, I'll die at home. And so acute respiratory issues, acute exacerbations of congestive heart failure, those sorts of things. The people don't get hospitalized. Those hospitalizations tend to be very expensive. Once they're in the hospital, the services, it's not so much of, all the extra services are being kept alive, because these are people who are very clear they don't want all of those things. What it is the expense associated with the hospitalization and the transport itself. And the other big, enormous savings, again, is reduced emergency room utilization and reduced visits to the emergency room. And in a way, again, there's a lesson here for the entire healthcare system, because it's not just older people with advanced illness who go to the emergency room because they're having some kind of serious symptoms at 11 o'clock at night or on a Saturday and need to know if it's serious or not, and can't find any other way to get somebody to pay attention to. Every one of you who's ever been the parent of a baby knows that those instances happen all the time as well. And good pediatric primary care medical homes have somebody on the other end of the phone, and there are a lot fewer emergency visits for those families as well, but those cost a lot of money. And for older people who are frail and have complex advanced illness, the actual expense of the emergency room visit itself is only a part of the costs of the anxiety, of the deterioration and conditions of the way the emergency room physicians doing their jobs will totally mess up and undo the work that the patient's regular physicians and nurses have been doing. And then, God help us, the patient gets admitted, or even worse, spends 1 day and 23 hours as an observation patient, and by the time they get back home, they're really a total wreck. And their condition is much worse off than before the onset of whatever the condition was that took them to the emergency room. And again, the issue here is those programs that are dealing with fee-for-service patients, by avoiding these emergency room visits and by avoiding these terminal hospitalizations, are saving Medicare a lot of money, but they're not getting to see any of it, which, even if it's not, they're not losing money on those patients, the fact that somebody else is making a lot of money on those patients really upsets them. And they want to figure out how to get their share. Or they can say, the hell with you, I'm not going to do it because you don't pay me extra for it. What do we need to do in order to see more of this and to expand these kinds of programs? Again, they're not going to expand under the fee-for-service model, even if, and we spent a lot of time and a lot of work trying to figure out ways to sort of help providers who live in a fee-for-service environment make a go of it with these programs. And the only way they can do it, and we're working on one particular example at the moment, is by subcontracting to capitated providers for care of the very high need and patients, and taking a shared savings or subcapitated amount. This may be actually a particularly good population, assuming CMS could ever get the risk adjustment models right, and assuming they could ever get the data to the ACOs in a timely enough fashion. This could be a really good population for a shared savings kind of payment model. Because people don't want to lock in. It's one of the reasons people don't enroll in hospice too late. It's an acknowledgement of irreversibility. It's an acknowledgement they don't want to get better. Your dignity-driven decision-making ACO is going to have the same problem. PACE programs sort of have the same problem. On the other hand, not only shared savings models, but whether or not these programs work well from a financial point of view, from a managerial point of view, for fully capitated plans also depends on the extent to which risk adjustment mechanisms adequately reflect the needs of these patients. And that's really hard, because when you have symptom-driven risk adjustment models and good community-based care prolongs life and may prevent exacerbation of some of the symptoms, your existing formulas may not work all that well. The other thing we need, and again, I already mentioned it, but I think it's really critical, we really need appropriate outcome and quality measures. And we need them because it's the right thing to do. We also need it, frankly, because this is not, and I was talking to someone last week about it, the sort of death panel allegations are not a passing thing. They're not a one-time phenomenon of the Tea Party in 2010. We dealt with them in 96 and 97. The whole reason the abomination of so-called private fee-for-service plans were part of Medicare Plus Choice was a conviction on the part of some of the same communities and some of the same people that the whole Medicare Advantage or what was then the whole Medicare managed care program was a government plot to euthanize all the elderly as a way of saving the government money and Medicare money. And their response to it was that particular one at the time. But the fact is, if you say we can identify a part of the population which is just as happy if in the last 6 months of life they forego intentional interventional medical treatment. And in doing that, we can save Medicare a lot of money. People are going to be suspicious. And I'm not entirely sure they're wrong to be suspicious. And I'm not entirely clear that we can show that in the 20 years the Medicare hospice benefit has existed, it saved Medicare more than a nickel or two. So that may be part of the problems of the benefit and the way in which it's administered and so on and so forth. But if our principle is, if our goal is to say we want to make sure we are giving people what they want, there is a fundamental human right and an issue of fundamental human dignity when people have advanced illness of being able to get the care they want determined by their needs and their wishes as well as by clinicians, then we got to damn well be able to prove it in significant detail in an intellectually and statistically robust kind of way. And until we have the ability to do that, our anecdotes are always going to get countered by their anecdotes. This is a place where measurement really, I think, makes a difference and is really hard. And it's going to take a while. And of course, nobody wants to wait that long. You also need organizations that really want to do this, which is hard. And then we need, we have a whole generation of clinicians who we have to train and we have to recruit, we have to keep in the business, we have to support them, and so forth. And I will just finish with this one illustration from real life, and I hope she'll forgive me because I didn't ask her permission, of using the illustration. About 3 years ago, 2.5, my mother-in-law had replacement of a heart valve at a hospital associated with the sponsors in one of our prototypical programs on the West Coast. And she was 84 years old at the time, although otherwise in generally good health. And there were some post-operative complications, as is not uncommon, including a minor stroke and so forth. But the operation was a success. And in fact, I can say 2.5 years later, she's doing extremely well, and both her neurological and cardiological health are excellent. But she was discharged from the hospital, this being California, about 4 or 5 days after the surgery, even having had the intraoperative stroke in the process, and was sent home. And while it never occurred to the surgeon, fortunately, my wife yelled and screamed at enough people so that home care services were arranged. And 2 or 3 days after she came home, later than was appropriate, but eventually a nurse showed up, again, from a home care agency owned by the same healthcare system with this model program. And the nurse showed up. She introduced herself to my mother-in-law and said, we have a number of things to talk about. First, I have an advance directive form I need you to fill out. That was a total calamity, but that is happening every day in homes of Medicare beneficiaries who are not terminally ill, as my mother-in-law was not, all over the country. Partially that's a misunderstanding of bureaucratic requirements, partially it's a really crummy home care agency, but largely it's a question of training, educating, supervising a whole generation of healthcare professionals in how to do this kind of stuff. And until we can change payment all we want, but we can change policies all we want. We can educate the public all we want. But until we have professionals who can deliver these services in a way consistent with these models and these goals, we're going to be pushing the rock up the hill. I've already talked for longer than I was supposed to after showing up late. I apologize for that, but if people have any questions or comments, I'm happy to try to respond. Yeah.
Hi, I'm Judy Paris.
Hey, Judy, how are you?
Good
Hiding behind there.
with each other, including when you were in Jersey. Oh, sorry.
Yeah, you're not
Hi.
old enough to say that, but it's okay.
I think we're all aging in place together. And in that regard, thank you for your good work, and thank you for trying to bridge what the acute care world knows of the other side of the world. What I did notice is when you were talking about integrated systems and PACE as groups that can pull this off, the growing movement of palliative care has also been shown to start with some of the reduced hospitalizations and knows how to have these kinds of iterative, dignity-driven conversations with people. So I think that would be a
We
good
spent a
addition.
lot of time about the relationship between dignity-driven decision-making and palliative care, and between palliative care and hospice care. And it's a whole nother, like, ultimately fruitless 6-hour discussion there. But the principles of palliative care, primarily in terms of care planning and symptoms management, are principles that have to be part of any DDDM-based program. But I would argue, and it's one of my continuous fights with Diane Meyer and people like that, I would argue are characteristics of good clinical care of anyone. And part of the problem with palliative care and expanding the availability of palliative care and so forth, and particularly of getting physicians and hospitals to order palliative care consults, is the boundary between palliative care and good clinical care is still not clear enough in lots of different instances. So in a way, you're entirely right. In a way, I'm not sure how far further down the road that gets us, because all of these programs were providing care consistent with the principles of palliative care, but they were doing lots of other things as well, and they wouldn't define themselves as being involved in palliative care. So, yeah.
So I'm Lena Nguyen, and I'm a physician and medical educator. And I want to say, first, thank you for the excellent talk, but also I totally agree with you with regard to lack of training and the better job that all of us have to do with clinicians to train them on these sensitive issues. What I'm wondering is, how do you balance this with the limited time and the increasingly limited time that clinicians have in doctors' visits, especially with the pressures to see more patients, but also with increased pressures to do medical records? I mean, already our patients talk about how there's this computer between them and their patients, right, and all these check boxes that we have to do.
Well,
so can reimbursement change, or is there a way to get non-clinicians to also help with this process?
You know, I would feel a little awkward about redefining every question in terms of personal experience, except if you read the introduction to Hobbes's Leviathan, which is the seminal work of Western political science. He talks about the superior methodology of the social sciences being introspection. So, but again, having been to the dentist yesterday really has the lesson, because they figured out, and the answer is, spending 15 minutes on a patient visit, 20 minutes with a patient visit, is impossible for a physician dealing with a patient with serious advanced illness, even if the patient's there every month, to do everything they need to do in those visits. On the other hand, the notion that you spend the same 20 minutes with every patient in a mixed practice is loony. It's, you know, and again, the 90%, I think, of what happens during a primary care visit in the typical pediatric or adult medicine setting can be done by someone who's not a physician. And I have had